And okay, so thank you everybody for coming to the Acoustic Neuroma support group that we have here in Palo Alto. Today I want to do a talk that I think I've only given this talk one other time before, and it's to talk about less common symptoms related to acoustic neuromas and providing an explanation for why those symptoms can sometimes occur. So these are what we all know are the common symptoms for acoustic neuromas, and this is what I'm not going to cover today. Tinnitus is the ringing in the ear, and then the hearing loss, and these top two would be the most common set of presenting symptoms: hearing loss and ringing in the ear. Ear fullness, dizziness, vertigo, balance issues. These are all very, very common symptoms. So we're gonna pass on these because there's lots of discussion on them, and we'll talk about some of the less common symptoms. Okay, so this is a picture of the undersurface of the brain, and there are a number of what we call these cranial nerves that come out of the brain and go to the face. And the olfactory nerve is number one, that smell. The optic nerve is number two, that goes to your eyes. If we look down here, what we see is the vestibular cochlear nerve. That's the hearing nerve, and the balance nerve number 8 right here. That's where the acoustic neuromas come off of, the vestibular nerve there. But you can see there's clearly a whole group of other nerves in addition to just the nerve that the acoustic neuroma comes off of. The first nerve I want to talk to is this big blue nerve here called the trigeminal nerve. And the trigeminal nerve provides innervation to the feeling of the face. So not the movement of the face, not the muscles of the face, but just the feeling of the face. So when somebody touches your face, or you feel pain in the face, or you feel warmth from the sun, that's all the trigeminal nerve. And it's you can see it's the biggest nerve there. It's usually a very strong and robust nerve. Now, the two symptoms that you can get related to the trigeminal nerve that we see with acoustic neuroma patients are face numbness and face pain. So face numbness occurs in about 5% of acoustic neuroma patients, and it requires the tumor to be large enough such that it is pushing on the trigeminal nerve. So if you have a small 1 centimeter acoustic neuroma, it's not going to be large enough to push on the trigeminal nerve. But when you start getting up to about 2.5 centimeters or larger, it's going to be pushing on the trigeminal nerve, and the patients can experience some face numbness. And so commonly I see a patient, they'll say, I have numbness around my lips, or my numbness on my lip and my chin. And when we talk about options for management, one of the main questions I will ask a patient is the numbness that you're currently experiencing, is that something that you could live with if it didn't change for the rest of your life? Because if the answer is yes, I could, then the options of surgery and radiation are on the table. If the answer is no, I can't live with this numbness for the rest of my life, then that eliminates the radiation option, largely because to eliminate the numbness, you have to remove the pressure of the tumor on the trigeminal nerve, and that would require surgery. So the trigeminal nerve is also called the fifth nerve, and the acoustic neuromas grow off the eighth nerve. So sometimes, in addition to the numbness, the trigeminal nerve carries also pain fibers, because they're part of the normal sensation, and it's possible for a patient to experience very sharp face pain. It's called trigeminal neuralgia. It's a sharp electrical shock-like pain to the face, and that's usually we see that in patients without an acoustic neuroma, and it's related to a blood vessel such as this pushing on the trigeminal nerve, and it's indenting the nerve like this. With an acoustic neuroma, we can have situations where the tumor, as it grows, gets behind the blood vessel and pushes it into the nerve even more, kind of creating a sandwich between the tumor and the nerve. So the blood vessel gets pushed into the nerve more, by the tumor, and that could take a patient who didn't have any face pain and cause them to develop face pain going forward. So if a patient does have face pain, it again makes it much more likely that we would say surgery is necessary to get the tumor off of the trigeminal nerve to alleviate those type of symptoms. So most of the time, if you present only with this face pain, trigeminal neuralgia, it's sharp electrical shock-like pain around your cheek and your chin and your mouth. It's often misdiagnosed as something dental. And patients, if they don't get an MRI scan to find the acoustic neuroma, often undergo some dental work, root canals, things like that are pretty common. And so it's a symptom that once you diagnose the acoustic neuroma, everything kind of falls into place. But if this is your only presenting symptom and you have normal hearing and don't have the ringing in the ear, it can be tricky to diagnose. These are the branches of the trigeminal nerve, how they innervate the face. There's three main branches. I call them the forehead, cheek, and chin. And you can pretty much get a sense of which branch of the nerve is involved based upon where the pain is distributed. So that's the trigeminal nerve. That's this blue nerve here. Now, if we look down around where the vestibular nerve is, this pink nerve here, you see another nerve right next to it that's labeled here called the facial nerve. So the facial nerve is the seventh nerve, and the vestibular cochlear nerve is the eighth nerve. So the facial nerve runs right next to the eighth nerve and runs out that internal auditory canal where we see acoustic neuromas commonly develop. So let's talk about what symptoms you can get that are related to the facial nerve. So first of all, the facial nerve is pretty strong. It's a very hardy nerve. So even though tumors invariably are pushing on it and stretching it, it's not common to get these symptoms. These are very rare symptoms. The first symptom you can get is facial twitching. And if you can look at this little statue head here, this is kind of what we see with facial twitching. The affected side, in this case, is the left side, scrunches up. So you can see the statue's left eye is shut, the mouth is drawn up, and there's a lot of creases in the skin here. And this is uncontrollable facial twitching. It's usually very annoying because it happens at the least opportune time. And it's related to the facial nerve being too active, meaning it's irritated, it's firing, it's causing the muscles to constrict. It's an overactive nerve. Now, you can also have the opposite problem, facial weakness. And in this little cartoon here from the Mayo Clinic, in this patient here, the right side is weak. The left side is normal. So when you have a weak face, you can't get your eyes all the way closed. If you try to close your eyes, your mouth doesn't move upward when you attempt to smile, and your whole face kind of sags down. A lot of times the sagging is even more profound than this kind of cartoon illustrates. And this is a result of the facial nerve being weak. So twitching or spasming is the nerve being too active. Usually that means the nerve is irritated. Weakness usually occurs when the nerve is more than just irritated. It's actually being impaired. And these are both uncommon symptoms because the facial nerve is very strong, and it's unusual for the facial nerve to be impacted, even if the tumor is pushing on it and stretching it. Now, related to the facial nerve is a tiny little nerve that's like the size of thread, or a little bit bigger than a human hair, but let's say the thread from a sewing kit. It's called the nervus intermedius, and it's this tiny little thread that runs between the seventh nerve, which is the facial nerve, and the eighth nerve, which is the balance and hearing nerve from which the tumor actually arises. This tiny little nerve innervates only one little part of the body, and that's your kind of eardrum, and it's only a sensory nerve. So if this nerve is irritated, you can get what's described by the patient as deep ear pain. And when you ask the patient where's the pain located, they'll say it's deep in the ear, like where the eardrum is. They won't report any pain on the outside of the ear, like in the earlobe or anything like that. They don't typically report pain in the face in the three distributions of the trigeminal nerve that I just showed you, but just isolated deep ear pain. And it feels like someone's poking an ice pick into their ear canal. So, this is kind of where the pain is located. You notice they're touching the ear lobes. That's not where the pain is. The pain is kind of deep in the ear. This is a very, very uncommon symptom, but we can sometimes see it if, the acoustic neuroma is always pushing on this particular nerve, and on occasion it causes this unusual symptom. We're still talking about the facial nerve, which is the seventh nerve, and two other symptoms that are really, you might think are hard to, how are we going to piece this together with the tumor, is that you can get a dry eye, dry mouth, and a change in taste. So there are some small branches of the facial nerve that go to the glands in and around the eye and the salivary glands in the mouth. And so if the nerve is dysfunctioning because of tumor pressure, you can have dryness in the eyes and dryness in the mouth. And this could happen even if the muscles of the face are normal. So you can imagine that if somebody just presented with a little bit of dry eye and the taste was being off, and that was the only symptom, it may be hard to kind of link that back to an acoustic neuroma, because dry eye, there's a lot of other reasons for having dry eyes in the modern world. Now, in terms of taste, on this image on the left side shows a picture of the tongue here. And if we look at the right side of the tongue, you can see the distribution. This kind of bluish area is part of the tongue innervated by the fifth and seventh nerve. So the trigeminal nerve and the facial nerve innervate this part of the tongue for taste. And then when you get further back, it's nerves 9 and 10 that innervate taste. So if the facial nerve is off, or if the part of the trigeminal nerve is off, you can develop an abnormal sense of taste. Things just don't taste quite right. And again, if this is the only symptom, it's going to be hard to put it together with acoustic neuroma. But if you have an acoustic neuroma and you have these symptoms, it's fairly straightforward to explain potentially why they can happen. So in addition to we're kind of working our way down. We talked about the fifth nerve. We talked about the seventh nerve. This is an intraoperative photo of one of my cases. This is around acoustic neuroma. You can see these kind of brighter white structures are the seventh and the eighth nerve, but you see a number of these smaller pinkish lines here. These are the lower cranial nerves of 9 and 10. So 9 is the glossopharyngeal nerve, and 10 is the vagus nerve, and they're actually related to a sensation of the back of the throat. If somebody sticks a tongue depressor down there and you gag, they've actually stimulated the back of the throat through the glossopharyngeal nerve. And these nerves also involve swallowing function. So if you think about swallowing a piece of food that you just ate, it requires a coordinated constriction of muscles from kind of the top of your mouth all the way down to the bottom of the esophagus to kind of push the food along. And so the ninth and 10th nerve are involved with the swallowing function. And so a couple of things can happen if these nerves are impacted. You can see in the illustration here, this tumor is not quite big enough to be really pushing on the nerves. And if you can imagine, if it was bigger and pushing on the nerves, that can sometimes cause throat pain. The ninth nerve innervates the back of the throat, and the patient can have very bad throat pain. And if that's a sensory function of the nerve, the sensation component. If the motor function of these nerves is impaired, then that constriction of the muscles to push food down the stomach becomes impaired, and that can cause some swallowing issues that make sense once you put things together, but may not make sense necessarily on their own if they're the only symptom. So this is another one of the pictures of my intraoperative surgery. Here's the ninth and 10th nerve lying together there, and we're carefully dissecting tumor off of those nerves. Okay, so we've talked about the nerves. This is the last of the uncommon symptoms that I want to talk about, and then we'll open it up to some questions. But this is the one of the symptoms that can lead to memory issues if you have an acoustic neuroma. Okay, so these are slices of two brains that are higher in the head than the level of the acoustic neuroma. So we're really not looking at acoustic neuromas in these slices here. We are looking at the fluid-filled spaces of the brain called the ventricles. And so on the right side, the fluid is black. You can see these ventricles are fairly small. We would classify these as almost slit-like ventricles there. But in the patient on the left, you can see the ventricles are very dilated and large. There's a lot more fluid in this black-gray area here on the left than it is on the right. And why does that happen? So your brain produces about 2 soda pop cans worth of this cerebral spinal fluid per day, or CSF per day, two cans of soda pop. It's the way I always describe it to patients. If it produces 2 cans of fluid, it needs to absorb 2 cans of fluid, because if you put in more than you're taking out, then you're going to have a buildup of fluid. And that's kind of what hydrocephalus is. The mechanism by which this fluid forms is it develops in the center of the brain, and it flows out through cracks and channels in the brain to the outer surface of the brain, where it's then reabsorbed by the body through a kind of filtration system, for lack of a better word. Now, the acoustic neuroma tumors can secrete protein. As they grow, they release protein into the spinal fluid, and spinal fluid normally has some protein in it, but not very high levels of protein. And as you can imagine, if you have an acoustic neuroma and you secrete high levels of protein, that is more likely to kind of gum up the drainage system of this fluid. So the fluid's produced in the center of the brain. It floats to the outside of the brain, where it cushions the brain and then gets reabsorbed by the body. In absence of this reabsorption by the body, the fluid can build up. Now, if the fluid builds up and you do get hydrocephalus, the 3 main symptoms are balance issues. You walk imbalanced, which can be somewhat of a problem if you already have an acoustic neuroma causing balance problems. And it may be difficult to separate out balance related to hydrocephalus with balance related to the tumor just growing off the balance nerve itself. So balance may be a little bit difficult to interpret, but urinary incontinence is another symptom related to hydrocephalus. In patients with hydrocephalus, this buildup of fluid puts pressure on the frontal lobe of the brain that is involved with urination. And if that happens, you can have some urinary incontinence, and coupled with some balance issues means you can have some trouble getting to the bathroom before some accidents occur. The third symptom related to hydrocephalus is actually memory issues. So, they asked, how could an acoustic neuroma cause memory problems? It really can't cause direct memory problems based upon the location of the tumor. But if it causes hydrocephalus, then memory issues is the third component of a triad. Balance issues, urinary incontinence, and memory issues is a third component of the triad that can lead to this development of hydrocephalus. So this is potentially how somebody, and I should say this protein secretion happens if you're in the watch and wait mode. It can happen after radiation mode. It certainly, surgery dramatically increases, at least temporarily, the protein and that buildup in the spinal fluid, and is kind of the most likely scenario to lead to hydrocephalus compared to radiation. We've even seen patients that have just been in the watch and wait mode develop this hydrocephalus and become, symptomatic secondary to it. So this Gary, would be how potentially somebody with acoustic neuroma could develop some memory issues if there was, still some blockage residual in the fluid of the brain. It can be treated with a shunt, and a shunt is a bypass system consisting of a pressure valve that will take the fluid pressure off of the head. And if the hydrocephalus is the cause of the memory disorders, then shunting it has a good chance of reversing the memory disorder. we'd like to see balance issues, incontinence, and memory disorder issues, because that usually gives you the highest chance that you'll be successful in correctly making the diagnosis versus just finding somebody that has just one of the three. It's like somebody just has urinary incontinence, but their walking is great and they don't have any other issues like memory disorders. Then it's going to be hard to say that the tumor is the culprit here.